All right, size. Size doesn't always help you distinguish lesions, although there are certain lesions that tend to grow very large, and that would be ameloblastoma, ossifying fibroma, then less likely some of the other ones. But those are the two that really grow large like that. In fact, when I see an image like this where it's some jaw tumor, usually that's going to be in some third world country because here we would get it treated in most cases sooner than that. It's almost always ameloblastoma in that case, especially older patients. Ossifying fibroma might be a younger patient. Here's another ameloblastoma. But then the size can also help you differentiate dentigerous cysts from hyperplastic follicle, because hyperplastic follicle is somewhat common. A hyperplastic follicle meaning the follicle grows around the crown of a tooth and it just looks larger than normal. But if it's not more than 5 millimeters from the surface of the crown of that tooth, you're not necessarily thinking dentigerous cyst. But once it grows beyond 5 millimeters, that's kind of the cutoff of, okay, and yeah, now it's probably more likely to be a dentigerous cyst. And if you see it growing and displacing other structures, those are good signs that it's a cyst. Same thing with nasopalatine duct versus a nasopalatine duct cyst. I've seen a lot of anatomical variation with nasopalatine duct, especially with 3D imaging. At this point, I've looked at tens of thousands of cone beam CTs, and so I've seen my share of varying anatomy. And you'll see that nasopalatine duct really almost expand like it looks like it's a cyst. And the book answer is if it's not more than 6 millimeters, you're not really going to suspect a cyst. And after my experience of looking at so many of these variant nasopalatine ducts, and the first couple I saw like that looked like a cyst that was growing, and it was only about 5 millimeters, maybe even 7 to 8 millimeters in diameter, I said probably a nasopalatine duct cyst and sent those for pathology. They came back as just normal nasopalatine duct tissue. And so since then, I've kind of increased that to really if it's more like, it can be more like a centimeter, 10 millimeters in width before I really start thinking of a nasopalatine duct cyst. But if it starts displacing structures, obviously, if you get a swelling in the posterior part of your anterior palate, that's a good sign that it's a cyst. If it's displacing the teeth around, likes to grow in between the central incisors and can displace those, then you know there's some type of pathology going on there. And then last thing, osteoid osteoma versus osteoblastoma. They used to be accepted as different lesions, but then looking back through literature, they're starting to conclude that those are probably the same lesion. The only difference is the size. When they're below 1.5 centimeters, they've called them osteoid osteoma. When they're larger than that, they call them osteoblastoma. And that's another one of those radiolucent rim around an opacity type of lesion. Giggity. All right, the S in our lesion acronym, in addition to size, should remind you to describe the shape of it. So these are all kind of synonyms: circular, round, ovoid, hydraulic, or cystic. But especially when it starts looking like a water balloon, you might call it hydraulic or cystic in shape. And so when the borders of it really start to adapt to surrounding cortices, like that one I showed you that sat on the floor of the maxillary sinus, or if it kind of adapts and bends to a surrounding inferior border of the mandible or whatever cortex it might be, that's a good indicator that it might be a cyst. It's hydraulic in shape, it's cystic. Sometimes the borders will scallop. This is a key indicator of it scalloping between the roots of teeth, as you see here, between the roots of the mandibular teeth as it's going up and down. That's what we mean by scalloping border. That's a strong indicator that it's one of two things, either an OKC, which this lesion happens to be, or a simple bone cyst. When I get to that lecture, I'll talk about the difference between those two. OKCs also tend to scallop just around borders of the mandible as well, but really have a strong tendency to scallop around the roots of teeth. All right, irregular. So this can sometimes be a tricky one. If I see a lesion that's just strictly radiolucent and it has what looks like a well-defined border, but it's really irregular and jagged and ragged, maybe what I would describe as a moth-eaten appearance, leaving little bits of trabeculation behind, that's a strong indicator that it's probably something malignant. And I talked about that in the malignant lecture. But not everything with an irregular border is malignant. We see in this case, part of it has a smooth border, but part of it is kind of jagged and irregular, but it's well defined and it's completely radiopaque, pretty uniform. This is just a dense bone island, idiopathic osteosclerosis. You can also tell from that intact PDL space here that it's not likely, at least, to be condensing osteitis, an inflammatory lesion. This is also a dense bone island. Very similar. Maybe not quite as uniformly opaque as that one, but that's okay. There's some variation with idiopathic osteosclerosis lesions. But it has that ragged border as it's just kind of filling in the marrow space. That's what a dense bone island is. Just fills in marrow space with cortical bone. So as we get to internal structure, radiolucent are dark things in our radiographs, radiopaque meaning things that appear light in our radiographs. Which one is more typically dense, or which one blocked out more radiographs, more of the X-ray radiation as it passed through the patient and to the film or the image sensor? Radiopaque means it's more dense or thicker. There's more substance that attenuated the X-ray beam. And so that's why bone, teeth tend to be radiopaque, especially cortical bone, enamel. Enamel is the densest, most calcified substance in our body, and that's why it appears so radiopaque. When something's dark starts to develop into a carious lesion, you get demineralization of that structure. That's why it appears dark. It's losing its density. And so you're going to start there when you're describing the internal structures of pathologic lesions. But when something has mixed density, you can get really specific with the description. We'll talk about what some of these different things are. This is an article I really like by an oral radiologist. He talks about 20 classical signs in oral and maxillofacial radiology. A lot of this deals with that internal structure. I think one of them was that scalloping appearance I just talked about. Most of them, though, deal with very specific descriptions of internal structure. So a lot of times you'll see loculations inside a lesion. And that shape, the form of the loculations, in a lot of cases can tell you what specific type of lesion it is. So interesting read. I always present these to my classes. I also have a lecture specifically on internal structure or different descriptions that are very specific to certain types of lesions. And so there are different things that cause a mixed internal appearance. A lot of times it deals with the trabecular pattern of bone, when the trabecular pattern is altered. So here's normal trabecular pattern in bone. We said the maxilla is fairly spongy bone, has pretty distinct trabeculation. But here it looks like the trabeculation gets smaller, and then smaller spaces in between. It's kind of getting that ground glass appearance, or in this case, looks like more of a pitted surface. It really looks like an orange peel. This is another fibrous dysplasia. And then I already mentioned the ground glass appearance as a sign of fibrous dysplasia. We said fibrous dysplasia typically has an ill-defined blending border. This was one of the exceptions to that rule where the fibrous dysplasia had a well-defined border. So fibrous dysplasia, it doesn't always follow one single appearance. There are a lot of different presentations of fibrous dysplasia, but if I said the typical, it would be that ground glass and an ill-defined or blending border. And then this is just what you probably think it is, just a periapical inflammatory lesion. You have these radiolucencies at the apices that's surrounded by what I would call sclerotic bone. And then that sclerotic bone has an ill-defined blending border from where that sclerosis ends to where the normal trabecular pattern picks up again. But some of these lesions, mostly benign tumors, will cause internal septations. There's just a couple of exceptions to that. But internal septation, it's developing these small little pockets, usually filled with fluid, and then the bone is remodeling around those pockets, and you get these multiple pockets. That's what causes this multilocular appearance. So don't confuse the term multilocular with multifocal. You remember multifocal, it's distinct lesions in different parts of the jaw. Multilocular, this is all one lesion, but it's different compartments. So those compartments are what we're calling multilocular. And then this, if I got more specific, I would describe this as soap bubble. This one also appears soap bubble in appearance, nice round loculations. This one down here is a little bit different. It doesn't have those round loculations, but more angulated loculations. And that's what the book describes as tennis racket appearance, very specific for odontogenic myxoma. This one kind of looks similar, but the septations are even more wispy. They're kind of faint, and that's kind of classic for central giant cell granuloma, those wispy, faint loculations. Other things that may do that could be a simple bone cyst, maybe an infected, any one of these other structures. We said infection can lose to loss of that nice, well-defined border. The same applies to trabeculation. but this is a central giant cell granuloma anterior to the first molar. This looks like where it developed, just anterior to the first molar. And then sometimes you get dystrophic calcifications internally that cause a mixed appearance. This is showing just a residual cyst, which is not known to cause calcifications, but it's showing that any long-standing cyst or lesion, if it's long-standing over time and chronic inflammation can occur internal to the lesion, it can develop these dystrophic calcifications. So usually kind of delicate, sometimes particulate calcifications within a lesion. But then there are certain ones that are more known to cause internal calcifications, and those are central odontogenic or calcifying odontogenic cyst, calcifying epithelial odontogenic tumor, adenomatoid odontogenic tumor, ameloblastic fibroodontoma, or some of the ones that are known to cause calcifications. So it's pretty rare that you get one of the other lesions, like a residual cyst, to cause calcifications like this. Or just amorphous bone. In this case, it's somewhat homogeneous. This is one of our radiolucent rim around it lesions, what I call target lesions. The radiolucent rim around an opacity. So I said that was specific for about 8 different things. 3 of those 8 are seminoosseous dysplasia, the different type. So this is likely just the focal variety of seminoosseous dysplasia. And in some cases, you get tooth structure inside. This one doesn't necessarily look like individual teeth, but it's more of an amorphous mass. And if you compare the radiopacity of some of this, and it's more opaque than even dentin, you got a good bet that you've got something laying down some enamel-like substance. And so odontoma is by far the most common. Ameloblastic fibroodontoma is another one that may do that. That's a little more rare. Odontomas are really common compared to any of these structures. And so odontoma is a good bet. And this one you can tell right away. It looks like little small malformed teeth, multiple teeth. And is this just multiple supernumeraries, or is this an odontoma? With the way they look so malformed and some really tiny ones, good chance that that's going to be an odontoma. The difference is just academic though. Same treatment where you do want to excise these if they get in the way. But these are going to stop growing when the teeth stop growing. There's a limit to odontomas. They're not true tumors. And so in a lot of cases, odontomas can be left. So only in a case where it looks like it's causing problems or going to cause problems do you want to excise odontomas. They're not going to recur. Like I said, not a real tumor. All right, stop and think about this one for a second. Quiz yourself. If a lesion is very ill-defined, invading and eroding surrounding cortical bone, by that description, does it sound like something benign or more aggressive, like an aggressive osteomyelitis or a malignancy? Hopefully you chose the latter. That's an aggressive lesion. And in this case where I don't see any degree of sclerosis, sclerosing bone, I'm going to go with malignancy until proven otherwise. All right, I made this Euler diagram thinking I was really clever and it was going to be really helpful. In hindsight, I look at this and it's just kind of an eye chart, but maybe you can make some sense of it. So we have 4 different categories of lesions here. Inflammatory lesions, including osteomyelitis, including periapical inflammatory lesions. We have malignancies, and we also have benign tumors, and then we have cysts. So here in the left column, we have radiolucent, radiopaque. You can see most things tend to be radiolucent. That doesn't really help you distinguish between what type of lesion it is. Oh, and on the left column, the inflammatory and malignant, I include these as aggressive. Cysts and benign tumors, I'll call these benign. So whether it's aggressive or benign, they can be radiopaque or radiolucent. Most cysts are going to be uniformly radiolucent, but in some cases they do develop calcifications. Even in the case of keratocyst, which I can't keep track of whether it's a cyst or a tumor lately, the World Health Organization goes back and forth. It is currently designated as a cyst, so an odontogenic keratocyst, and that can form some calcifications or at least some loculations internally. But there are a couple of cysts that actually cause calcification internally. But let's look at this. The IDWD, what's that? Ill-defined in the red, well-defined. These things always tend to cause more well-defined borders. Whereas aggressive, almost always, we have a couple exceptions here, aggressive lesions cause an ill-defined border. I guess one of the big exceptions, a lot of times inflammatory disease, periapical lesions can form well-defined borders. And so the thought question is, which best determines whether a lesion is benign or aggressive? Is it the periphery, which we said right here, ill-defined or well-defined, or is it the internal structure, radiolucent, radiopaque? Hopefully you tell by this, that's the whole point of this, is that well-defined things tend to be benign, ill-defined things tend to be aggressive, so inflammatory, malignant. The reason I included this is because I've seen a lot of dentists say, oh, it's radiolucent, therefore it must be a malignancy, or it's radiolucent, therefore it must be benign. No, that doesn't really tell you anything. But the border can tell you a lot about the lesion. All right, and I said this is an often forgotten descriptor, the effect on other structures, but it is also very important. It's one I see left off all the time, and something that could tell you things about the lesion that probably would have changed my differential from what some people put. So it implies its behavior. Inflammatory stimulates bone resorption or formation, as you saw with those periapical inflammatory lesion. Why is it radiolucent right at the apex? That's where probably the most dense accumulation of those inflammatory byproducts are, and so it's causing a resorption of the bone around it. That's how the body is reacting. It's resorbing bone where the infection is the most intense. And then around the periphery of it, it's more of a sparse accumulation of those inflammatory products, so more of a chronic reaction to it. And the chronic reaction is what I think of as bone formation, that sclerotic bone around the periphery of any type of inflammatory lesion. All right, what is a space-occupying, slow-growing lesion? What does that tell you about a lesion? If it tends to occupy space and move teeth around, push canals around, displace the borders of canals or the borders of bone, all those are signs of something more benign. And so if you see any of those borders pushed around, or if you see something that has a corticated border around it, strong indicator that it's something benign. Fast-growing, destructive lesions really tends to resorb bone. Maybe it follows paths of least resistance, grows into the PDL spaces, grows into canals, destroying cortical borders. All those are indicators of something more malignant or something a lot more aggressive. All right, so here's an example of tooth displacement. Which teeth are being displaced? This third molar is being displaced posteriorly. The second molar, actually that's a second molar. This is a young patient. That's the first molar being displaced inferiorly. And so this is around the crown of the tooth. It's well defined. It's displacing teeth in different directions. We can tell it looks like it's coming from the follicle of the tooth. All those signs that it's something benign. There is an exception though. If a tooth is displaced coronally, meaning something growing from in the apex of the tooth. Do periapical lesions displace teeth and so they'll displace them coronally? No. Does cemento-osseous dysplasia, which tends to develop in the apices of teeth, displace teeth occlusally? No, it doesn't. Typically the things that do that are these malignancies, and I think of the 3 L's: lymphoma, leukemia, Langerhans. I talked about those in our malignancy lecture, which a lot of you haven't gotten to yet. But those 3 L's are malignancies, although there is a benign variety of Langerhans. I just lump it in with malignancies though. Those are the malignancies that displace teeth coronally. So be aware of that. Be wary if you have a very young patient that has a tooth that's just developing, probably shouldn't be erupting, that's starting to erupt. And it looks like the crown's not fully developed. And if you push on the crown of the tooth, you might get blood arise from around the sulcus. That's a sign of which of these? Could be a leukemia. All right, in this case, what's the effect on other structures? Is it displacing cortical borders? Yeah, this is not a natural, normal border of the mandibular ramus. It's being displaced kind of outward, upward, and anteriorly. Maybe a little bit of displacement of the posterior border, the inferior border. Kind of enlargement of the mandibular angle. And so there is displacement of the cortex. When it's maintaining the cortex around it, a strong sign that it's something benign. What's the other effect on other structures? These teeth, is this the normal tooth position, or is this? No, that's displacing those teeth anteriorly, in this case inferiorly. All these are signs of something benign. This was a cherubism. I talked a little bit about cherubism versus basal cell nevoid. Cherubism occurring in even younger patients, very expansile, but also the location of this being posterior to the teeth, developing more in the mandibular ramus or angle, and then pushing the teeth forward, and we don't see other lesions around the odontogenic region. That's a sign of cherubism as opposed to basal cell nevoid. Cherubism tends to occur after 5 or maybe around 5 years old and anywhere around the dentition. It can displace teeth, but in any of the odontogenic regions. We also see some of the cherubism lesions in the posterior maxilla as well, pressing this tooth forward. This tooth may be coronally a little bit, so maybe an exception to that 3 L's rule. Okay, what did I just say about this? Here we see this nice, smooth bordered, well-defined lesion, but where's the displacement of that tooth? Here we have a first molar not even erupting. This patient's maybe 6 years old because the first molars are just erupting. Don't be confused by this. They're just missing that premolar there. You can see the premolars developing here and here. And so this is a deciduous second molar. And so this is a second molar that's erupting way earlier than it should. Just starting to calcify the cusp tips of that tooth. Erupting coronal, we said, lymphoma, leukemia, Langerhans. Lymphoma, radiographically, you're not going to see in younger patients. In younger patients, that's Hodgkin lymphoma, and that typically only develops in soft tissues, in the lymph structures. Langerhans can affect young children, but if it's in the apices, developing in the periapical regions of teeth and pressing teeth coronally, typically that's leukemia. But Langerhans might have a second on the differential there. All right, here's another sign, tooth resorption. Same image here, but now we're focused on the effect on that tooth right there. It might be displacing it anteriorly a bit. It looks like it is displacing this developing premolar, but there's also resorption of the distal root of that deciduous tooth. Now, deciduous tooth roots, they do tend to resorb fairly easily. They're kind of built for resorbing. But this has a nice smooth pattern that follows the pattern of the border around it. That's a very benign sign. So a sharp line, continuous margins of the lesion. Whereas a malignancy, it can resorb roots, but it's more irregular and more resorbs roots from the periphery out, not in a straight line like that, but it leads to spindle-shaped roots, kind of like spiked roots. And so that's why spiked root shape is a strong indicator of a malignancy. And look at the PDL spaces as well. It's not always a sign of something bad. In this case, it's orthodontics causing PDL spaces, lamina dura to widen, but it's uniform PDL spaces where it maintains that nice smooth outline to the PDL space. That lamina dura maintains a smooth, intact border here. And so that's what I would call uniform PDL space widening, which may be a sign of trauma, like we show here, tooth movement. Whereas this is a bit different. See how there's more irregular destruction of that lamina dura? Somewhat a blended border around the apical portion of the teeth. Here we have more of an irregular pattern. It's not nice and smooth and uniform PDL space widening, especially along this border. The ill-defined lucency around it. That's what I would describe as more irregular destruction of the lamina dura or irregular PDL space widening. And that is a strong indicator of a malignancy. And why is that? Malignancy, we said they tend to follow the path of least resistance. Once some of the malignant cells start getting into the PDL space, they really start expanding from there, and then it resorbs the lamina dura around the PDL space. So that's what we're seeing in both of those. And I starred that one because it is very important. Recognize that sign. Know that that's a sign of malignancy. It can even help you distinguish when something looks somewhat like an acute osteomyelitis. You're not sure whether it is or not. Malignancies are the ones that really tend to go within the PDL space like this and destroy the lamina dura. So similar to that, we get our tooth floating in air appearance. You have to distinguish between malignancy or inflammatory. If I got probably 99 cases of teeth floating in air, or if I got 100 cases, probably 99 are going to be inflammatory just because periodontitis is so common. You know, people lose bone all the time around their teeth to an extent that they can lose their teeth. But in this case, we get kind of an ill-defined, ragged border. So if you see that tooth floating in air, combined with that ill-defined nature of it, where we don't see sclerosis indicating an infection, which, you know, periodontitis is an inflammatory process. And so if you see just the ill-defined destructive nature of this radiolucency, good indicator that this is a malignancy rather than inflammatory. And then this is a great image because it actually shows both. What do we see around this molar? You see this nice smooth border, a little sclerotic border to it, which tells you what, inflammatory or malignancy, more likely. that it's inflammatory. A big chunk of calculus here helps as well. And so this is just a periapical or a periodontal lesion. Well, it's both. It's a perioendo lesion at this point because it encompassed the roots of the teeth. But everything about that says inflammatory. What about this tooth, which is floating in air here? More ill-defined, destructive, invasive property of this lesion. And so this one worries me a lot more. And this is where I believe the malignancy is in this case. Of course, now it's probably extended all the way through the bone here. And so hopefully that helps with malignancy versus inflammatory. Let's go on to displacement of the inferior alveolar canal and the mental foramen. Superior displacement is strongly associated with fibrous dysplasia. It's almost pathognomonic. So in this case, even though it looks kind of patchy and mixed, almost cotton wool appearance, that is one of the presentations of fibrous dysplasia. As I said, fibrous dysplasia can present in a lot of different ways. It just doesn't have that classic ground glass appearance. Then it may be hard to tell what we're looking at here. It looks like a lateral projection, a lateral oblique projection of the jaw where it's taken from the side. It'd be like this. The patient's head is against the sensor, and then the radiograph or the x-ray comes in from below to image the jaw. And you can see the canal displaced all the way up here. And there's this much bone beneath it. And so there's superiorly displaced inferior alveolar canal. Widening of the canal. If you remember that case I showed you where the cortex of the canal just looked like it widened like a snake eating an egg, that was a good sign of a benign neuroeurovascular lesion. But if it's irregular widening, where it's just destroying the cortical bone around it, that's going to be a similar sign to that irregular PDL space widening, where it's destroying the lamina dura around the roots of the teeth. And that is a strong indicator of malignancy. All right, so what was this one? Hopefully you recognize coming from within the canal, expanding those borders. Does this look, by the appearance, by your description, hopefully you're describing in your head, and it should lead you toward, is this more likely well-defined, or is it more likely benign or malignant? It maintains that cortex around it. It's nice and smooth. And if you said that, you could describe to me on the phone, and I could tell exactly what type of lesion this might be. And so this is a benign neuroeurovascular lesion. Contrast that with this one, something that's expanded all the way along the canal. I'd be hard-pressed to really describe this as ill-defined, but it does have somewhat irregular borders, maybe some trabeculae left behind. But the way it's really destroying all the borders along the canal of this tooth is a good indicator, especially, I guess, when combined with that ragged appearance, irregular appearance. Indicator that this is a malignancy. In some cases, you can get arteriovenous malformations that cause serpentine expansion and changing of the canal, which can look pretty similar to this. But usually those are going to maintain a cortex around it, maybe not quite as nicely defined and delineated as we saw in that last case, which was a schwannoma. But compared to this, it should maintain more of a cortex around it. And so this is a sign of malignancy, that cortical destruction. I was showing you this several times already, just an inflammatory lesion, but we're showing how this is actually an effect of the lesion here. It's creating a stimulated bone reaction. It's sclerotic bone. It's osteoblastic activity that's being activated by the infection and laying down more bone. It looks like more numerous trabeculation. And so that's what I typically mean by sclerotic borders. There are some cases of metastatic tumors that cause the bone to do that increase the osteoblastic activity. Those are the gender-specific ones, so prostate or breast metastases. What about if something is expanding the cortex outward, like we see here in this occlusal radiograph? Do you see that nice well-defined line around it? That means that cortex is being maintained, even though it's being thinned, but it's growing slow enough that the periosteum of bone is able to lay down more calcification, a little thin layer of cortical bone around it, which tells you what, more of a benign or aggressive, malignant behaving lesion. It's more likely something benign, and this looks very cystic. Back here we see that intact cortical border. This also shows, so this is an axial slice in a CT. If you're not used to looking at 3D imaging, you might have no idea what we're looking at here, but there are maintained cortical borders around it, but it has outstripped the ability of that periosteum to lay down new bone. But the fact that it does maintain some cortex expanding around part of the lesion at least tells me that this is more likely a benign lesion than a malignancy. It's just growing a little bit more rapidly than you would expect with most benign lesions. And that's how ameloblastomas are. They tend to grow rapidly. As I said, certain ones really tend to grow fast, and they're the ones that can tend to grow large. And then if you look at the shape of the expansion, that can help you distinguish between certain types of lesions. This one that has a nice ball shape is a certain type of lesion, whereas if it looked the same with this cotton wool appearance, this looks really cloudy and cotton wool, well-defined, kind of a maintained cortical border around it. But this could be one of two things. I'm thinking ossifying fibroma or fibrous dysplasia. And that pattern, that nice round pattern of expansion, tells me it's more the ossifying fibroma. A lot of times those ones have a lucent border around it, but maybe it's not as distinguishable in some cases as others. And so compare this one and contrast it with that last image. It's not quite as round. There's still expansion of the lesion. Cortex in this case still remains intact, but this lesion tends to thin the cortex, and eventually over time you just kind of lose the cortex. But internally it does look either ground glass or cotton wool, but it's that expansion pattern that distinguishes this from the last one, and this one's the fibrous dysplasia. Whereas ossifying fibroma tends to just grow in a ball in a round shape from wherever it starts, fibrous dysplasia grows along bone and expands, kind of maintaining the shape of bone from there. This looks like it's an occlusal radiograph of the mandible. Fibrous dysplasia occurs a lot of times in the maxilla as well. The posterior maxilla is a good place for it, and it can just expand and really start occupying the maxillary sinus. Here's another effect that you can recognize on other structures. It's the periosteum laying down new bone. And then why do we get a double periosteum here? The reason is that this indicates different amounts of activity of the lesion. At some point it's really active, and in this case it's osteomyelitis. In most cases of this onion skin or this parallel shaped periosteal reaction, it's going to be osteomyelitis. And so the osteomyelitis may undergo more of an acute stage where those inflammatory exudates lift the periosteum, and then it kind of goes into a refractory period and it stabilizes over time, more of a chronic stage of osteomyelitis. And then the periosteum is able to lay down a new mineralized kind of cortex of bone around it. And then that alternates back to the acute stage where it's lifting the periosteum off of that bone. And then it slows down and the periosteum is able to lay down new bone. And so that's how you get this onion skin periosteal reaction. And that's a strong indicator of osteomyelitis, although there are a few malignancies that do this. But you look at the bone here and it's very sclerotic, very patchy appearing. Some patches of radiolucency surrounded by the sclerosis. Not your typical of fibrous dysplasia, especially with the onion skin appearance. But if you just look at a certain part of bone, it may look kind of ground glass, and that part can appear similar to fibrous dysplasia. But that patchy appearance is an indicator of likely infection. Here's a different type of periosteal reaction where you get these little calcifications that are coming off in spindles, more of a 90-degree angle to where the lesion is arising from. The classic one that does this is osteosarcoma, although gender-specific metastases can do the same. They can cause calcification. They can cause this appearance of this sunburst or sun ray periosteal reaction. And hemangioma is another one that can do that appearance. All right, you've seen this before. First of all, identify the problem. Where is it? Right maxilla. Everything's just destroyed. And so this is showing that destructive can be a malignancy, or on the next slide we'll see that destructive doesn't necessarily mean malignancy. Look for other signs. Is this a well-defined or ill-defined lesion? Hopefully you recognize this looks more like a ill-defined border. This looks well-defined, but I said be wary of other anatomical structures bordering your lesion, and don't mistake an anatomical structure with being a well-defined corticated border caused by the lesion, because that'll send you down the wrong path of diagnosing. And so this looks like what's on the other side. That's the sinus or the nasal cavity, either the lateral border of the nasal cavity, medial border of the sinus, two sides of the same coin. And so that's a border that's not necessarily caused by the lesion. And then also you look at just the amount of destruction. I don't see anywhere you have a smooth, bordered, rounded, corticated border and this is more likely malignancy. As opposed to this one, it's still destructive. It's destroying a lot of bone, but is there anywhere in this lesion where you see a well-defined, even corticated, smooth border to it? Yeah, there are multiple areas. Look at the pattern of resorption of the teeth. Nice and smooth and straight across. That pattern of resorption kind of follows the pattern of the borders of the lesion, and that's a very benign type of resorption. Nice and corticated here on the posterior border, superior border. A little bit of expansion out here. Here it's maybe outstripped the ability of the periosteum to lay down new bone. It's displaced this teeth apically, this tooth. And so just showing that destructive doesn't necessarily always mean that it's malignant. Things can be destroying structures and still be benign. Do you think this is benign or malignant? How would you describe it? Does it have well-defined or ill-defined borders? The way that you can follow the border here, here's really the only place I see a distinct corticated border of the lesion. But the resorption of the roots of this teeth also follow that nice, smooth, rounded border of the lesion, really making it look nice and ball-shaped like a well-defined radiolucency. The displacement of this tooth, anteriorly and inferiorly, that's another sign of potential benign. And so all these are signs that this is a benign type of lesion as opposed to aggressive. All right, if it's very expansile, causing separation between teeth, likely benign or aggressive. If it really expands teeth around, probably more of a slow-growing lesion. Think of orthodontics. It takes a while to move teeth, right? Especially if you're bodily moving it through bone, as opposed to just tilting. And so when it's bodily being moved through bone, that's more of a sign of probably even a benign tumor as opposed to a cyst. Although cysts, they can push teeth around as we've seen. And so if it's very expansile, causing separation between teeth, more likely a benign type of lesion. All right, this is just a little outline to help you as you're going through your differential, and make sure you get to all the important descriptors of a lesion. It goes through our lesion acronym: location, external shape, size, internal, other, and number. Then also some bullet points here to help you remember maybe some of the terms you might use for these and the things that you should be thinking about when you're describing pathology. I won't go through every one of them right now. And here's a Mad Lib, if you've ever done Mad Libs, where you take a structured sentence or paragraphs and you put in certain words. And so this is to help you as you're describing lesions. For my students, I'll give you a worksheet with this, and you'll use this to practice describing certain lesions that you see, and that'll help shape your description. And then from that, you're going to develop an impression and a recommendation. So a blank, describe the periphery, the shape, the internal. So all three of those you can do at once. It's a well-defined, round, radiolucent lesion measuring size is however big it is. Then describe the location. Internal structure, you can describe it further if applicable. So if it was a mixed lesion, or if it's a multilocular lesion, then you start really getting specific about describing those loculations. Are they soap bubble? Are they tennis racket? Maybe it's mixed and it's ground glass or cotton wool. We'll get into more specifics as we get to some of the other lectures, where I just kind of touched them in this lecture. Then the lesion, don't forget the O. That's the big one. This is why the lesion acronym is so helpful for me. It seems like everybody tends to forget the O. They remember the external. Typically people describe the location and shape and the internal, but that's the big one that's forgotten. Describe the effect on other structures. And we'll talk more about this in the future, but you do need to come up with your impression. And I would say it's most consistent. Commit to one which you think it is. You can first describe the category, most likely benign odontogenic lesion, or maybe a malignant lesion, a malignancy. Most consistent with what? Ameloblastoma, or could be also OKC, COC, and any of these other things which I'll talk about in a lot of detail further on. It's recommended to biopsy this lesion or to monitor this lesion. And so when I'm writing a report, I try to be very descriptive with what I see, as well as give a clear and as concise as possible impression of what it might be and a recommendation of what to do with the lesion. All right, here are my references again. I hope this is helpful. Comment on my YouTube site if you have any questions for my students. Go ahead and email me. You know how to contact me. I can't hide from you. And I hope to see you on the next one. Thanks. Bye.